Before I turn over the hosting to Abdallah El Sayed Alam, I would like to say a prayer first. So let's pause for a moment for a special prayer. Let's pray. Our Heavenly Father, we come before your presence, oh God. We thank you for this opportunity that we can listen and learn this afternoon on the knee and its interventions. I would like, Lord, to entrust Dr. Abdallah El Sayed Alam to you this afternoon, that you give him wisdom and understanding, that he will be able, Lord, to deliver his lecture well, and it will teach us to learn new things. We pray for the rest of us who are still coming in, and I'm so happy, Lord, that you can join us this afternoon. Thank you, oh God, for your grace and your goodness. In Jesus' name we pray. Amen. So now I would like to welcome Dr. El Sayed Alam from Tanta University in Egypt. And I'm going to turn over to you the hosting so you can control your slides. So it's all yours now.
Okay, thank you.
Request everyone to turn your audio to off mode and then give your undivided attention to Dr. Abdallah. Okay, Dr. Abdallah, go ahead.
Okay, it's okay to start?
Yes, go ahead. Go ahead. Go ahead.
Good morning. I am pleased to be invited by Dr. Jim to join this important activity, webinars for teaching during COVID-19 pandemic. And I am pleased to present my presentation to all my colleagues. I think all of them more or less know what I will talk, but I want to present our perspective in management of osteoarthritis knee regarding interventions as a physiatrist and rheumatologist. Regarding the ultrasound guided interventions for management of osteoarthritis knee, I will talk about tips and tricks that are important in everyday practice and how to deal with the different pathologies, how to choose the patient, how to select the injectant, and how to correct the abnormal biomechanics as much as possible. All we know that ultrasound guided injection is better than blind interventions, providing accurate and effective deposition of the injectant at the target site and also avoid injury of collateral structures, and in knee avoid injury of the cartilage with the needle tip, or injury of genicular artery or nerve in your way while introducing your needle. Regarding interventions during COVID-19, all operators should have their personal protective equipment, sterilization of the ultrasound machine, sterilization of the bed, disposable sterile gloves, bed sheets, covers, face masks, and patients should change their clothes before entering the examining room as possible for protection and providing excellent service of interventions during COVID-19 pandemic. Regarding first tip is the needle visualization, and the best technique for visualizing the needle during intervention is the in-plane approach, while the needle is introduced parallel to the linear probe, while out of plane the needle is introduced perpendicular, so you can see it as a bright white dot. Also, we should care about the direction of needle introduction. If I introduce the needle parallel to the midline of the probe, I will see the whole length of the needle. If my needle is deviated little to the right or left, I will not see the tip, and injury will supervene. Portals of entry into the knee is superolateral or medial, lateral patellofemoral or medial patellofemoral, or anterior, and I will discuss the importance of the technique in the last slides and how to choose the portal of entry. And this is the in-plane approach, introducing the needle from lateral to medial into the suprapatellar recess. Okay, the second important tip is scan before you inject. Why I should scan before I do injection? First answer, you can find a strange pathology that prevent the intervention or make the intervention risky. In this patient, she has a medial knee pain, and she points to a mass in this area. Ultrasound examination revealed heterogeneous mass eroding the tibia. Ultrasound guided aspiration and sent to histopathology revealed sarcoma, metastatic pleomorphic sarcoma. In this case, scanning, even the patient do a plain X-ray, and X-ray reveals only osteoarthritis. As an operator, I should do a scan again by ultrasound before doing intervention. The second issue important for interventionists is effusion and synovitis. Effusion and synovitis are causes of pain in osteoarthritis knee, and also the effusion and synovitis interfere with some injectants. You know, if I inject hyaluronic acid in presence of a background of synovitis, hyaluronic acid might exacerbate an acute arthritis. Also, if I inject hyaluronic acid in presence of effusion, you know, effusion is rich in proteolytic enzymes. It will degrade the hyaluronic acid. So, if I find a effusion or synovitis, I should first aspirate the effusion, then inject corticosteroids. If I plan to inject hyaluronic acid, it can be done at the same session. If I plan to inject platelet-rich plasma or lyophilized platelet-derived growth factor, I postpone the injection 3 weeks after corticosteroid injection. It is important to eradicate synovitis and effusion. If I inject PRP on a background of synovitis and effusion, it might exacerbate the condition. You know that the inflammatory background will direct platelets to behave as destructive and inflammatory rather than reparative. Scan before you inject to see the pain generator. Sometimes the patient report anterior knee pain and points with his finger to the upper pool of the patella. The pain generator here is traction spare in the quadriceps tendon. So the target is shockwave therapy to this traction spare, or injection of corticosteroids or prolotherapy. In this patient, he has a severe osteoarthritis knee. You can see 2 kissing osteophytes and dislocated medial meniscus and meniscal cyst when the cyst was complicated. Really, for this patient, it is better to do surgery. Dealing with an osteoarthritis and complications like cyst and calcifications as a cyst necessitates advanced intervention, which is mostly surgery. If the patient is not agreeing with surgery or refusing surgery, I can do a nerve block. I can do ultrasound guided either saphenous nerve block or infrapatellar block of the infrapatellar branch of the saphenous nerve for relief of pain only. In this patient, many patients with osteoarthritis knee have a severe medial knee pain, and this pain sometimes described as a neuropathic pain that is radiating to the leg and to the medial side of the leg and the medial part of the foot. Usually those patients have entrapment of the infrapatellar branch of saphenous nerve as it passes in close relation to the medial collateral ligament and the anterior horn of the medial meniscus. Subluxated or dislocated medial meniscus press on the medial collateral ligament, which can be a cause of pain and sometimes entrap the infrapatellar branch of the saphenous nerve, especially on weight bearing or complete extrusion or dislocation of the meniscus. Sometimes with dynamic meniscus subluxation, we should examine the patient lying down and weight bearing to clarify the exact pain generator, because the patients report pain only on standing. If they are sitting or lying down, there is no pain. So it is mandatory for scan on weight bearing and non-weight bearing conditions. Regarding this image, you can see dislocated meniscus and 2 kissing osteophytes, meniscus pressing on the medial collateral ligament, and you can see hyperechoic deposits inside the meniscus. So we can have multiple pain generators at the same site, and multiplicity makes the intervention more worse. In patients with crystal arthropathies, it is better to inject corticosteroids if intervention is urgent. Otherwise, give medical treatment to eradicate the deposits. In gout crystals, you need at least 6 months for clearing of the joint from crystal deposits. And in such patients with subluxated or dislocated medial meniscus, I prefer to do block to the infrapatellar branch of saphenous nerve, then introduce my needle from superior to inferior, deep to the dislocated meniscus, depositing the injectant in the medial tibiofemoral compartment, aiming to mechanical push by the fluid, mostly hyaluronic acid. Then future regenerative interventions, I prefer to place the injectant at the sites of maximal compression. Patients with subluxated or dislocated medial meniscus, beside the intervention, they must reduce their body weight. Also, they should wear a lateral wedge insole to reduce body weight bearing and loading on the medial tibiofemoral compartment. So injection alone is not a solution. I must combine with the reduction of body weight and lateral wedge insole. This is important. Also, presence of gout crystals. You know, if I inject hyaluronic acid in osteoarthritis knee, or even BRP in osteoarthritis knee with a background of crystal arthropathies like gout, the needle might mobilize the crystals and unmask the crystals inside the joint, precipitating an acute attack of gout. So the rule is to treat the underlying associated pathology, either effusion, synovitis, or crystal arthropathy, then plan later the intervention. I don't know if the injection of stem cells in a joint with background of crystal arthropathies is not it does not precipitate an attack of gout. I didn't find any information in literature, but regarding corticosteroids, dextrose water, lyophilized platelet-derived growth factor, placental extracts, hyaluronic acid, we should first treat the crystal arthropathy before performing intervention, or use corticosteroids in addition to hyaluronic acid during injection. Scan before you inject, so you can delineate the anatomy. Here the genicular nerve pushed away by the effusion. If I introduce my needle at this area, I might do injury to this nerve. Some patients after injection say that the site of the needle introduction is feels paresthesia or tingling at the site of the needle introduction. This might be due to injury of a nearby nerve. Here in this photo, you can see the infrapatellar branch of saphenous nerve have 3 divisions, and all of them are, and the middle one and the last one are related to the dislocated meniscus and entrapped by it. So in this patient, what I want to do is block of the infrapatellar branch of saphenous nerve, then introduction of my needle to inject into the medial tibiofemoral compartment with reduction of body weight and lateral wedge in sole. Here vessel, so when I scan, I delineate the anatomy to avoid injury of nerves or vessels during my needle introduction. In this case, we have a collection of effusion and the lateral recess of the knee joint. The collection and the effusion push the iliotibial band away from the lateral femoral condyle. Such traction on the iliotibial band is a cause of lateral knee pain. Injection of steroids or eradication of the effusion followed by prolotherapy to this area is very beneficial and can prevent recurrence of the collection in this area. In this patient, ultrasound scan revealed entrapment of the iliotibial band in the short axis view between 2 osteophytes, and this was the cause of pain. And the treatment might be injection of corticosteroids or hyaluronic acid to minimize friction with the osteophytes, or shock wave therapy to the osteophytes on the lateral femoral condyle. Scan before you inject. For this patient, he has a severe osteoarthritis knee, medial meniscus dislocated, and meniscus, you can see a large meniscal cyst. If I aspirate the cyst and inject corticosteroids, then target the medial patellofemoral compartment, and I can't advise this patient to use a lateral wedge insole, because if he uses the lateral wedge insole, the lateral collateral ligament will be markedly stretched over osteophyte on the lateral tibial plateau. So in patients with medial meniscus extrusion or subluxation, it is important to scan the lateral collateral ligament. Many of patients have stretched lateral collateral ligament. The question in those patients is if there is an osteophyte on the lateral tibial plateau or not. If there is osteophyte, I will not advise the patient to wear lateral wedge insole. If there is no osteophyte, the patient must wear a lateral wedge insole. For patients with stretched lateral collateral ligament, which can be a cause of lateral knee pain, like the iliotibial band, I do sometimes block of the lateral collateral ligament. Okay, for this case, for this patient, I will introduce some images for the same patient to clarify the importance of ultrasound scanning before injection. In this patient, I scanned the medial tibiofemoral compartment and the medial meniscus in this sequence. Okay, and you can see the medial meniscus is dislocated with 2 kissing osteophytes throughout the whole width of the medial tibiofemoral compartment. For the same patient, on the lateral side, doing examination, you can see stretched lateral collateral ligament. Also, in doing an ultrasound scan for the patellar tendon, what we can see when we place the probe between the tibial tuberosity and lower pool of the patella, I should see the full length of the patellar tendon with clear fibers throughout whole length from lower pool of the patella till tibial tuberosity. In this patient, I can see clearly the proximal part of the patellar tendon. When I tilted the upper pool of the probe slightly laterally, I can see the whole patellar tendon clearly. This is due to the lateral shift of the patella. Lateral shift of the patella is due to loss of cartilage in the lateral patellofemoral compartment. Loss of cartilage on the lateral patellofemoral compartment will produce a traction on the patellar tendon. The traction on the patellar tendon might be a cause of anterior knee pain in osteoarthritis knee patients. Scanning the medial, so in this patient, I placed the probe while he is flexing his knee 16 degrees between the patella and the medial femoral condyle, and you can see the distance is very wide, and lateral patellar border and the lateral femoral condyle, you can see an osteophyte, and the distance is very narrow. This confirms the lateral shift of the patella. For those patients, I inject the hyaluronic acid into the medial tibiofemoral compartment, and I inject into the lateral patellofemoral compartment, with advising the patient to wear patellar tracking orthosis with lateral compression bar to neutralize the position of the patella, so it will minimize the lateral knee pain due to hypercompression of the lateral patellofemoral compartment and the anterior knee pain due to traction on the patellar tendon, together with reduction of the body weight and wearing of the lateral wedge insole. This is important. Also, degenerative meniscal tears can present in patients with the osteoarthritis knee and should be targeted with regenerative interventions during treatment of the osteoarthritis knee. So I stress on the dynamic scan for detection of the meniscal subluxation, which means root meniscal injury, and also reduction of body weight, lateral wedge insole, and injection into the medial tibiofemoral compartment is important. As regards the posterior knee pain, we know the Becker cyst, which can be fluid only or synovial thickening in chronic long-standing cases, and we must differentiate it from thrombosis of the popliteal vein. But Baker cyst is not only the cause of posterior knee pain. We can have in our patients tendinopathy of the membranous tendon, cortical bone irregularity at the insertion of the tendon in short axis and long axis views, and it should be treated with rehabilitation stretches of the muscle and tendon, and reduction of body weight, correction of the medial tibiofemoral compartment abnormality, and sometimes we might need a tendon block. Also, posterior knee pain can come from the entrapment of the posterior femoral cutaneous nerve. And finally, spasm of popliteus is not uncommon in patients with osteoarthritis knee, and patients report abnormality in unlocking of the knee while extending the knee from flexion position. We should scan the popliteus, and we can see thickening of popliteus in the side of the spasm, and just ultrasound guided block of the popliteus muscle will relieve the posterior knee pain. So it is important to scan before injection. Scan before injection to see the cause of pain. Scan before injection to study the abnormal biomechanics of the knee joint and how to deal with the altered mechanics as much as possible using lifestyle modifications like body weight reduction, orthosis like lateral wedge insoles, where to place the injectant, and the underlying knee pathology like gout crystals or presence of synovitis and effusion. All these factors are important to scan for before doing an intervention. Regarding the choice of the injectant, we have in Egypt corticosteroids, dextrose water, platelet-rich plasma, lyophilized platelet-derived growth factors, placental extract, hyaluronic acid combined with collagen, single syringe, hyaluronic acid with allogenic stem cells, and botulinum toxin. So the choice is, first of all, is cost effectiveness, and mostly patients pay by his own pocket for the injectants. So economic state of the patient is important in Egypt in the choice of the injectant. If I combine local anesthetic, I can combine local anesthetics with corticosteroids and with hyaluronic acid, or do nerve block before doing the intervention, like block of the saphenous nerve or the infrapatellar branch of saphenous nerve if I will inject into the medial patellofemoral compartment, because it is painful in cases of meniscal subluxation and dislocation. I should take in my consideration the chondrotoxicity of local anesthetics, and the mepivacaine is the least chondrotoxic. So if I will inject intra-articularly local anesthetic with corticosteroids or with hyaluronic acid, I will choose the mepivacaine. Hyaluronic acid can be combined with corticosteroids. Corticosteroids must be spaced between it and dextrose water, platelet-rich plasma, and lyophilized platelet-derived growth factor, 3 weeks at least. We have a study in Egypt combining a very low dose of corticosteroids with the placental extract at the same session, but I think the same rule should be applied to the placental extract. Also, botulinum toxin can be combined with corticosteroids, hyaluronic acid, and BRB. Combination depend on the severity of pain, presence of the pathology and the abnormality of biomechanics. All we know that the BRP and lyophilized platelet-derived growth factor and dextrose water and placental extract need multiple injections for induction of regeneration, might be up to 10 injections. There is no standardization between frequency between different studies regard when to repeat the injection, weekly, 2 weeks, monthly, every 2 months. There is no standard spacing between injections except for hyaluronic acid. Regarding the choice of the injectant, it depends on evaluation of our patient regarding systemic factors like diabetes, bleeding tendency, use of non-steroidal anti-inflammatory drugs, autoimmune disorders, and immunosuppressants. In cases of immunosuppressants, we can't use BRP or lyophilized platelet-derived growth factor or dextrose water. It will be inhibited by these drugs. In cases of bleeding tendencies or using anticoagulants, so we can't use platelet-rich plasma, and also the INR should be less than 3.7 to avoid hemarthrosis. So it is important for evaluation of the systemic cause. If the patient is diabetic, I should look for coexistent diabetic polyneuropathy, because if I will do the intervention, the patient will report a residual pain. So scanning and of the nerves around knee and distal at the ankle will give an opinion about the condition of peripheral diabetic polyneuropathy before start of injection. And I must tell the patient that you have an element of peripheral neuropathy besides the osteoarthritic knee pain. Evaluation of the local knee mechanics, as we said before, presence of synovitis, effusion, crystals, and this is important for choice of the injectant, as we said before. Regarding the botulinum toxin, it has a direct analgesic effect, treats the peripheral and central sensitizations, and has an anti-inflammatory. And we proposed, according to our experience, body weight dependent dose for botulinum toxin and sport. And I prefer the intra-articular botulinum toxin injection in osteoarthritis knee over the genicular nerve block, because the long effect of botulinum toxin and greater impact on relief of pain, better than genicular nerve block. I don't practice radiofrequency or cryoablation, so I can't give an opinion about the genicular nerve radiofrequency or cryoablation. Regarding the adductor canal block, it is very effective in relieving most of the medial posterior knee pain, because the adductor canal connects with the popliteus plexus posteriorly, which supplies the whole posterior knee. So if I have medial and posterior knee pain, I can choose the Hunter canal block as an option for relief of pain, then plan for regenerative interventions later. And I prefer to introduce my needle from cranial to caudal, just lateral to just medial to the vessels, to avoid injury of nerves accompanying the saphenous nerve inside the canal. Regarding genicular nerve block, Professor Stanley provided with Professor Thomas Clark in their interesting book, clear imaging of the different genicular nerves, anatomic landmarks, and how to target them. and the ascending recurrent genicular nerve from common peroneal can be blocked in osteoarthritis knee, and it is important to scan between the fibula and the patellar tendon, opening the power Doppler to see the accompanying vessel. It is difficult to see the nerve itself. So now we will see the needle clearly and avoid injury of cartilage or nearby vessels and nerves. We scanned to know the pain generator, the internal condition of the knee, and the abnormal biomechanics. Regarding the technique, I prefer in the cases of the medial meniscus dislocation, reduction of body weight, lateral wedge insole, injection into the medial tibio-femoral compartment, introduce needle from proximal to distal, to the dislocated meniscus. The aim is to benefit from the mechanical push by hyaluronic acid or the injected fluid. Also injection of the regenerative medicines like PRP, dextrose water, and placental extract. I inject into the sites of the maximal mechanical stress. This procedure is painful, so I do an infrapatellar branch of saphenous nerve block or saphenous nerve block before with local anesthetic before doing this intervention. And after the injection, the patient wears lateral wedge insole. In patients with lateral shift of the patella to the lateral side, I inject into the lateral patellofemoral compartment to benefit from the mechanical push by the fluid and induce regeneration in this area if I use a regenerative injector. Together with the patellar tracking orthosis and lateral wedge insoles, because to optimize the effectiveness of injectant, the interventionist should deal with the mechanical abnormality and abnormal mechanics, so the injection can last longer than reported in textbooks. Here is the injection into the lateral patellofemoral compartment. So injection into suprapatellar recess or medial tibiofemoral is okay, but this is the patellar tracking orthosis with lateral compression to realign the platelet location at the midline during extension and flexion. Regarding the anterior approach, either on the medial side of the patellar tendon, as in the video, or the lateral side of the patellar tendon, mostly if you don't have the proper needle length, you are injecting into the Hoffa's fat bag. So I don't like the anterior approach, and I don't use it anymore. If you inject hyaluronic acid or inject PRP, the patient will not benefit. On injection of corticosteroids, some patients feel relief because of the systemic effect of corticosteroids, not the local effect. So regarding the technique, inject into the sites of the maximal stress and don't use the anterior approach. And thank you very much.
Okay, thank you very much, Abdallah, for that beautiful lecture. So, any question from the floor? Do you want to ask Abdallah regarding his presentation? So if you will notice, he discussed a lot of the technique and of course the approach that he is using different solutions, using different approach, and with the effect of really relieving the pain that the patient came in for complaint. So the first question here is, what are the indications of botulinum toxin for the knee? So that is the first.
I inject the botulinum toxin intra-articularly in cases of severe osteoarthritis knee. Okay, to do targeting of the genicular nerves, you have multiple portal entries. So I prefer to inject once using botulinum toxin combined with hyaluronic acid after eradication of effusion and synovitis. It has a long-lasting relief of pain. Sometimes you can find patients with multiple pain generators in the knee. Which structure I should inject? You can find many pain generators. The patient says pain in whole knee, and when you evaluate with ultrasound, you can find more than one pain generator. So I inject the botulinum toxin to block the pain transport through sensory nerves of the knee.
Okay. So do you have any follow-up for that, Melaine?
Yes. Good morning, doctor. Thank you so much for your wonderful lecture. I would just like to ask, if you inject the botulinum toxin injection, do you do the hyaluronic acid on the same day?
Yes, yes.
Same clinic day that the patient sees you?
What?
Do you inject both the botulinum toxin and the hyaluronic acid on the same day?
Yes, because first there is no drug interaction between hyaluronic acid and botulinum toxin. The second issue is to minimize the patient visits to the ultrasound unit, because every visit the patient pay by his own pocket. So doing injections, multiple injections in same session is to reduce first the cost of visits, and there is no interaction or complication regarding this. I inject the botulinum toxin into the knee since 7 years ago, alone or in combination with hyaluronic acid. So no problem, but both of them potentiate the pain relief to the patient.
Thank you so much for this. This one is a new knowledge for me, doctor. So thank you so much for sharing this one.
You are welcome.
Okay, another question from Dr. Domingo here. Do you want to ask him personally, Dr. Jojo? Would you like to ask him directly? So anyway, the question of Dr. Domingo is, do you inject botulinum toxin intra-articularly? How much botulinum toxin do you inject? Maybe
according to the body mass index. According to the body mass index, if you see the lecture, okay, our publication with my colleague Felice Galuccio, if the body mass index range from 25 to 30, I inject 50 units of botulinum toxin and 100 units of Dysport. If the body mass index range from 30 to 40, I inject 100 units of Botox and 200 units of Dysport. If the body mass index is more than 40, I inject 200 units of Botox and 400 units of Dysport, because personally I found that if I inject obese patient with 50 or 100 units, the effect is very short.
Okay.
And we have a study already.
So the other question.
We have a study already in my department in collaboration with my colleagues in Asyut University about the injection of botulinum toxin in osteoarthritis knee doses in comparison to radio frequency. It will be published. We are finishing the study for submission to publication.
Okay, another question from Dr. George. The question is, when you are injecting into a ruptured meniscus, how much volume do you place into it? Or do you activate your PRP before injection?
What he means by ruptured meniscus means tear, meniscal tear, or subluxation, or dislocation.
Yeah.
What is the meaning?
Okay, George, can you clarify that, George? Hi, George.
Hi, Abdullah. I recognize that question is kind of vague. I guess what I'm trying to understand is I don't put a lot of when I have a ruptured meniscus, I don't put a lot of volume into it. I'm just curious if you're using higher volume. I've heard people.
What do you mean by a ruptured meniscus? Tear, meniscus tear?
It's extruded. We have a tear, a fissure straight down the, under ultrasound. You have maybe disruption of the meniscofemoral, meniscotibial ligaments, very similar to the images that you showed.
Okay. Do you mean, let us talk about meniscus extrusion first, okay? You know that we have a dynamic meniscus subluxation, then fixed meniscus subluxation, then total meniscus extrusion, okay? You have 3 degrees. First degree is the dynamic. When the patient stands, the meniscus subluxate. When the patient sits or lying down, the meniscus relocate into the medial tibiofemoral space. Later, you have a fixed subluxation. Either the patient lying down or standing, the meniscus is subluxated, but not more than 15% of the meniscus is subluxated. Extrusion means more or less whole the meniscus is subluxated or dislocated from the tibiofemoral compartment. So in dynamic subluxation, I prefer reduction of body weight, lateral wedge insoles, and injection into medial tibiofemoral compartment to regenerate and strengthen the meniscotibial and meniscofemoral ligaments, and to strengthen the ligaments that hold the roots of the meniscus in their place. So I inject into the medial tibiofemoral compartment. I think 1 or 2 milliliters of the injectant is enough, either PRP or dextrose, for 3 to 6 sessions with 1 month interval in between. Regarding the fixed meniscus dislocation or subluxation, you need to inject more than 3 or 6 times PRP, placental extract, combination between PRP or placental extract or hyaluronic acid. Any volume you can inject, you will benefit from the mechanical push and benefit from the regenerative ability, but just do block with local anesthetic to the infrapatellar branch of saphenous nerve or the saphenous nerve as the adductor canal, because the injection at this area is painful. I don't activate PRP before injection because PRP platelet tissue interface activates the platelets directly.
Okay, so do you have any follow-up question, George?
No, thank you. That was very informative.
Okay, thank you. There's another question here. Do you have experience doing PRP and genicular block at the same time?
I didn't do this before in combination. I didn't inject PRP in combination with genicular nerve block, but if we will do the block will be done only with local anesthetics. I will not add the corticosteroids because steroids inhibit repair by PRP. So this is my advice. You can do or radiofrequency to genicular nerves. You can combine it with PRP, but take care that PRP preparation for the osteoarthritis knee, you need non-heme contaminated PRP because heme is toxic to the cartilage and chondrocytes. You need leukocyte poor PRP because leukocyte rich will promote further damage. So be careful on using PRP in osteoarthritis knee.
Okay. Another question here. What is your experience about dextrose? How often are you injecting and how much are you injecting in each knee?
I use dextrose 10% or 25%, okay? And I inject from 5 milliliters to 10 milliliters in each knee, and injection every 2 weeks. Every 2 weeks. Till patient say, okay, there is no pain, okay? Or if my target is regeneration, okay, I will inject many times. I don't know when to stop, but this should be studied in randomized controlled trials when to stop dextrose injection if you achieve the regeneration. And how many times you need to inject. There is no strict data or guidelines about these points.
Okay, thank you, Dr. Abdallah. And I appreciate you for your very comprehensive lecture today. And I'm sure a lot of us here have learned new things from the experience of Dr. Abdallah. And thank you for your precious time that you've spent with us. And I hope we can do it again in the future, Dr. Abdallah.
I want to stress finally on that scan before you inject. Evaluate the pain generator and the abnormal biomechanics and optimize your injection by correction of the abnormal biomechanics. Treat the associated local knee condition, synovitis, effusion, crystal arthropathies before start of your intervention. And thank you very much.
Yeah, thank you very much, Dr. Abdallah. Any more questions? Before we finally let go of Dr. Abdallah, I just would like to make some comments also. Remember that when we deal with degenerative joint disease, we are dealing with 3 basic elements here. We are dealing with, the first one, of course, is a cartilage problem. And then even though this is a cartilage problem, there is also a synovial problem that goes with it, because the synovial layer is the source actually of the cytokines. These are the one that releases the pain generators that causes pain inside the knee in the form of what we call TNF-alpha, interleukin-1, interleukin-6, much like what we experience in COVID in cytokine storm. So this is the one that actually causes a lot of pain inside. But at the same time, there's also pain generators coming from the nerve itself, which are the neurotrophic factors that's released from the TRPV1, which are in the form of substance P and CGRP. These 2 substances are the ones where the dextrose can be very effective because they are the ones being targeted. And if you do it on an ultrasound-guided target, then you can actually hit the area. What Dr. Abdallah was referring was where the genicular nerves, the superior and inferior genicular nerves, medial and lateral. So this area, if you target them appropriately or precisely, then you can actually relieve all the pain. So if it doesn't work for one area inside the knee, maybe you have not also treated the neurotropic factors which is found around the knee itself that's causing the pain. So it's really a lot of holistic thing here. And the good thing is that while we focus on one area, or even if Dr. Abdallah has introduced the use of botulinum toxin, in the future, we will be listening with Dr. Lisa here, who will talk about just the use of dextrose for pain control. And I'm sure we will know a lot when that lecture is commenced 2 weeks from now. So I would continue to invite you to please come and feel free to attend. This is a free conference, and we appreciate the contributions of Dr. Abdallah. And I know he's doing a lot of other researches. We're working on something also on neuropathic pain, and hopefully this will all contribute to all the things that we are dealing right now. So thank you again, Dr. Abdallah, for your time. And I'm sure you're tired. You wake up very early in the morning.
Yes.
And hope to see you soon.
Thank you.
Yeah.
Yes, me too. Hope to see you soon.
Yeah, so thank you, everyone. Thank you for your questions. You don't have any other question?
Dr. Jim,
No more question? Oh, Pash is, okay, go ahead, Pash.
there was lots of interest about the use of PRP and other regenerative methods. Maybe in the future we can take note of that and have a specific maybe lecture time for biologics and other things like PRP and dextrose, and give it like when to inject it, how much to inject. There are some questions here that are dealing with that: where, when, and how much to inject. We'll take note of that.
Please repeat the question.
Thank you. So next week, yeah. Go ahead, Dr. Abdallah. You are saying something.
Repeat the question, please. She is Dr. Bash.
Okay, Doctor.
Asking for giving a comment. I didn't.
Okay.
I'm sorry, the signal might not be very good, but there are some questions still here. Maybe they can just connect to you after this lecture about how much PRP should be given, and then in what situation should we decide when to give and where to inject it. I think that there is a lot of, or there's enough curiosity about this topic, and maybe Dr. Jim in the future can also organize another lecture that's only based for biologics, so that there's much interest. I saw it in the chat just now.
Okay, so since you opened the topic, on Tuesday it's purely orthobiologics. Dr. Ken Moltner of Emory University will discuss about orthobiologics by Tuesday, so hold on to your questions, because we're gonna ask him directly as he provide us the lectures on Tuesdays. So you are all invited. That we will start by around 9 in the morning, Philippine time. It's always Philippine time. And hopefully by the time, if you have other questions, then you can ask Dr. Moltner. So again, thank you all of you, Dr. Abdallah, for gracing our Zoom conference today. And hopefully you have a nice weekend. Have a good day. God bless everyone. And be safe. Be safe.
Thank you. See you.
Any last words, Dr. Abdallah?
What?
Thank you.
Thank you. Thank you.